Good morning, good afternoon, good evening, wherever you may be tuning in from. Welcome to another exciting APA Live, Exploring Birth Psychology. My name is Wendy Bruns. I'm APA's Outreach and Communications Director, and I'm so excited to be your host for today, which is Monday, June 3rd of 2024. My goodness, moving into June already. APA Live is our weekly webinar series where we bring you experts and pioneers in the field of pre- and perinatal psychology and providing you insights that expand our understanding of conscious babies. Whether you're joining us from across the globe or just around the corner, we are so thrilled to have you here. I always love seeing where everybody's tuning in from. You're welcome to drop that into the chat. I have found tons of my neighbors watching this. I'm in Northern California. I'm in Sacramento. And so it's always fun to just make those connections wherever you may be. APA is dedicated to advancing education, research, advocacy in the field of birth psychology. And we encourage you all to become members. By becoming a member of APA, you will unlock access to exclusive benefits like our APA Live Library, getting course discounts, and of course, our APA Connect community meetings, which are a perfect way to connect and really have great conversations with our other APA members. But more importantly, you help support APA and expand our ever-growing mission. We're going to go ahead and drop a link into the chat to bookmark our membership opportunities along with my email in case you ever have questions or you don't have questions and you just want to say hi. I always love hearing from all of you. We're also going to go ahead and drop a link into the chat to our incredible PPNE program. It's our pre and perinatal educator program. It is our bread and butter here at APA. If you want to know more, you're diving into pre and perinatal psychology, that is the perfect course. And it's incredible timing. Our exceptional education director, Christiana Dykman, has been diligently going through all of the 12 modules and updating this incredible decade-old program with new research. She's really getting into the hands-on and somatic exercise piece and creating more opportunity for our students and our mentors to get to know one another. And it looks like Stephanie went ahead and dropped that into the chat as well. And while you're bookmarking those, let's go ahead and get started with today's APA Live. I'm so excited. We're bringing Magaletta-Snyder to our little corner of the world today. I saw you give a wave, Simone. I'm so excited. You are doing a presentation called Understanding the Experience of Birth Workers Who Witness Obstetric Violence. Simone is the faculty and staff training coordinator at the Rutgers University School of Social Work Center on Research for Ending Violence. Simone is a co-adjunct faculty member at both Rutgers and Monmouth University. You've worked as a community doula, a violence prevention educator, a hospital domestic violence response team coordinator, and she has spent the last 15 plus years of training on topics related to reproductive justice, maternal health, and gender-based violence. Simone is currently the DSW program in the DSW program at Rutgers, where her research focuses on maternal health and birth justice. And Simone received her MSW with a certificate in violence against women and children and obtained your undergraduate degree in anthropology and gender studies from New York University. And Simone was actually selected by the UN Women to serve as an ending violence against women expert. So we're in fantastic hands. I'm so excited. Let's please all welcome Simone to APA Live. And as we get started, please drop any questions for Simone into the chat. We always have some little time at the end for some Q&A. And I'm so excited, Simone. Welcome to this space.
Thank you. Thank you so much for having me. I will go ahead and share my screen now. I'm hoping to leave a good amount of time for us all to chat at the end because I recognize that there's a lot of expertise in this room and I'm really curious just to sort of hear about your experiences, your thoughts on some of what I will share with you today and just, how things are going in the world of birth work, wherever it is that you are. Like Wendy said, we're going to be talking about my research this year, where I interviewed 17 independent doulas and midwives about their experience witnessing obstetric violence in the delivery room or in the birth room. And so I'm excited to see where everybody's from, and that makes me really happy. I'm also curious to know about the work that you're doing, and also maybe something that you're hoping that we get to talk about today. That would be really helpful for me as well. And so while I'm going through sort of our agenda and what we're going to cover today, if you share that in the chat, Wendy will sort of collect that information and it'll help sort of inform our discussion towards the end. So my plan for today is, and this is very informal, I created slides just so you had something pretty to look at and don't have to just like stare at me using my hands the whole time. I am in New Jersey and I talk quickly and I talk with my hands. So if you need me to slow down, please feel free to just be like, relax a little bit, because this is something I'm very passionate about. I was thinking, I was trying to do the math again. And I was like, ooh, I think it's more than 15 years. Now it's like 18 years, which is wonderful, but also like makes me feel a little bit old, which is interesting, but very passionate about this. And so I could go on for days. But I'm hoping to at least leave 10 to 15 minutes for us to sort of get into a conversation about this as well. So my plan is to tell you a little bit about me, where I got, how I got here, why I chose this topic. I won't go too much in detail into the research in terms of the methods and thematic analysis and all of that, but I do think it's worth sort of talking about a little bit. We'll talk about my research questions, and then the bulk of what we're going to talk about is sort of the results and the themes that came out of these conversations. What's really interesting is that I had a wide range of folks that I spoke to all across the country. We had to, because this is not a PhD program and I wasn't doing this sort of like extended dissertation, I was limited in terms of, things like how many pages and how many people that I could actually interview. Our limit was 18, and I actually had a lot more. Most people for this particular research project only had about 5 people. And so that just sort of, and I mentioned that to say, the motivation for folks to reach out to me to talk about this subject was it was sort of mind-blowing. I actually had to turn some folks away. And so I'm hoping that this is sort of the first part of a larger project where we can give voice to individuals who are experiencing this and witnessing this and sort of how they navigate their decision-making processes. Then I hope to obviously end on sort of a positive note in terms of some ideas about how we're going to move forward. How do we create change? How are we going to address things like medical racism, maternal mortality, and obstetric violence? And this is where I'm really hoping to hear from all of you as well, too. So at any point, if you have any questions, please just drop them in the chat and or you could save them for the end too, and hopefully we'll get to all of that. So a little bit about who I am and sort of, I think it's important for you to understand sort of what brings me here, my positionality in this work. So I'm going to bring it back about 23 years. My oldest son will be 23 this August. And when I found out I was pregnant with him, I had a doula before I told anybody. I had a doula before I had a doctor. Like the doula was the first person that I reached out to. And I was first introduced to the idea of a doula in my undergraduate program at NYU in a women's studies class. And it was about a year later that I found out I was pregnant and hired a doula right away. I had a very stereotypical sort of, if that's a thing, experience of birth. I was probably at the hospital way too early, took a long time. I was coerced into some interventions that I probably would not have agreed to had I been truly informed. And then my 9-pound baby was born vaginally and stopped breathing in my arms. And so they took him away from me. They had him in the NICU for about a week, and nobody could tell me why. There was nothing wrong with him. He was big, but not, abnormally large. There were no issues, but they kept him from me for a week with no real answers. And so originally, when looking back on that experience, I didn't necessarily define that as traumatic, but I knew something wasn't right. So I became a doula pretty soon after that. And then I had my second child who was born at home. I was living in New Mexico at the time with a midwife and a doula. And that is when I would say I recognized sort of what my oldest son and I missed out upon. Like that postpartum period that I had with that home birth really sort of brought up this like this experience of like, wow, we really missed out on this with this first experience. So then as a result of that, so I've been practicing as a doula, but at that point I became a home birth midwifery assistant, and started doing a lot more home births. And I'm in New Jersey now, which is where I was raised, and where my first son was born. I also did work in New Mexico and California as well. And so, like I said, I've been doing this work for 18 years. I've experienced a lot of things, not even necessarily just in the birth room necessarily, but as a woman navigating my reproductive health, which I think has very much influenced my desire to sort of do this sort of research. And so over the years, I've learned a lot and experienced a lot about maternal mortality, gender-based violence, and sort of harmful medical practices. So a lot of people early on sort of couldn't quite understand how I was doing this birth work and also this gender-based violence work. And for me, they were always very much connected, because early on in my doula work, I found that I was working with survivors of sexual violence, child sexual abuse, domestic violence, and had absolutely no idea how to provide support because there were no trainings then. Not to say that there's that many more now. I do think it's a little bit better. And of course, I read When Survivors Gave Birth, because that's all that really existed for us. But I took it upon myself to start to volunteer at domestic violence agencies and sexual violence agencies. And I've done that in every state where I've lived and worked. And that's sort of what prompted me to go back to school for my MSW and to get that Violence Against Women and Children certificate, because I just, I didn't feel like I was supported or had the training to work with folks who are experiencing trauma or violence in their lives. And then sort of really got into that work as well. And so that's sort of where these two worlds started to collide. And so now I'm currently enrolled in the DSW program, which is sort of the practice degree as opposed to the PhD, which is the research degree. And so what we're going to talk about today is the research that I did during my second academic year. And I was motivated to do this for all the reasons that I already mentioned, but also because, and I'm sure that this may be the case where all of you live too, but in particular in New Jersey, I've been finding that a lot of the decision makers, policymakers, even politicians who are sort of raising awareness and wanting to engage in issues around maternal health, whether that be medical racism or maternal mortality, are sort of looking to community doulas and midwives to be the answer to these systemic issues. And that is wonderful. And I think that is great. And I think, we're getting lots more funding and a lot more attention. But I think what we're not doing is sort of reckoning with the impact that then has on the doulas and the midwives that are sort of taking up the mantle to do this work. And so that's what I really wanted to do. I wanted to understand the impact of witnessing obstetric violence, witnessing medical racism, and grappling with these different sort of systemic issues on these individual levels. And I think it's really important because I do think, there is research, and everybody on this call knows that doulas and the midwifery model of care improve outcomes. That's not up for debate. But what we're not looking at is how to better support our doulas and our midwives and our birth workers in a way that allows them to be able to do this work long time and in a sustainable way. I'm reminded of one of my participants who said, it's rare that they meet a doula that has been doing this work for more than 10 years because they burn out so quickly. And so that is sort of what I wanted to get to with this research. And so that's me, that's who I am, and that's sort of what motivates me to continue to do this work. So obviously, like many of us, I have been reading about this and doing research on this for a very long time, but this was the first opportunity I had to sort of really do this research in a systematic way. And so in the end, with my paper, I think I had about 30 different articles and books that I sort of brought in to sort of lay the foundation for why this work is important. This is just a couple of the ones that really resonated with me. The book on obstetric violence is a really wonderful new book. I think it came out just a couple of years ago, and it's sort of all these different stories about obstetric violence around the world. And one in particular chapter that was the most useful for me was specifically on doulas witnessing obstetric violence. And it was really fascinating to see the ways that the themes that came up in that research project came up in mine as well, which we'll go into in a little bit. And then these two articles here are they both sort of blew my mind a little bit, and really influenced not only this current project, but sort of where I see this going in the future too. And so I just wanted to give you the visual for those, but we will come back to some of those in a little bit too. So I just broadly want to go over some of the themes that came up in the literature review. And so this is not necessarily my research. This is sort of the research that I use to sort of set the foundation for why what I was proposing needed to happen. So in my paper, and even in this workshop here, I didn't spend too much time on statistics about obstetric violence or birth trauma, because in my opinion, those experiences are not up for debate, right? Like, we know they're happening, and we know that discrimination and racism are root causes of obstetric violence and maternal mortality. I think most of us here also know what we mean by obstetric violence, right? And so I didn't want to spend too much time defining that, although we'll go into it a little bit. What came up in the research and what came up in my interviews was obviously this wide spectrum of behaviors that are from subtle sort of shifts in energy to just outright violence. What I did think was interesting, and I'm sure many of you have noticed this too, when reviewing the literature, there's so much time spent on who says we should use obstetric violence, who's using disrespect and abuse, who's using mistreatment. And so many of my participants talked about that, because one of the things I asked them about was sort of how do they define this phenomenon, whether they're talking to their colleagues or their clients. And they all were so frustrated with the fact that it's like, let's just call it what it is. And I had one participant that said, like, of course I call it obstetric violence. What do you want me to call it? Spicy malpractice? Which sort of stood out to me, because I thought that was really interesting. There was even one journal that sort of had this whole ongoing debate back and forth about why we should call it obstetric violence, why we shouldn't call it obstetric violence. I feel, and many of the people that I engaged with on this project feel similarly, that we need to call it what it is, right? It is obstetric violence. It's not, yes, mistreatment is a piece of that, but when we're talking about sexual abuse and physical abuse and verbal abuse, that's not just mistreatment, that is violence. And so that's sort of where I landed with this. And when we're talking about obstetric violence, obviously we're talking about any sort of behavior that can be physical, sexual, emotional, perpetrated by a medical professional. And that can involve bullying, manipulation, coercion, non-consensual procedures, and many other behaviors that I'm sure many of you have experienced in your practices as well. I think what is really important to emphasize when we're having these conversations is that it is structural and it is institutional, right? It's not just the actions of one bad apple. There are power dynamics involved, and it is a form of racialized, gender-based violence that is normalized throughout the system. When we think back to sort of the history of obstetric violence, a lot of this language and a lot of this research actually came out of South and Latin America. Venezuela was the first, and I think there's a couple other, I think Argentina and Mexico legally recognized obstetric violence as a term under this larger umbrella of violence against women. And that is really important, because that is how we get funding. That's how we get research. That's how we get policy to address these issues. You have to first acknowledge that it is an issue. And I think we're coming along here in this country, in the United States, but it's been a long time coming. I think back to 2009, Amnesty International put out a report on deadly delivery, which was all about maternal mortality in the United States. And I volunteered to be an advocate or a delegate on that. And, that entailed reaching out to legislators, and no one returned my phone calls then. Nobody wanted to have this conversation. And now we're in this place where people are willing to hear what we have to say. But it frustrates me a little bit, because I'm like, okay, but like, had you been listening back then, maybe we wouldn't be having this maternal health crisis that we're experiencing now. The other big theme that came up in sort of this foundational research and in the work with the people that I interviewed was this issue of systemic change, right? So like I talked about already, birth workers are being tasked with changing the system, right? And there's lots of funding and attention going to training doulas, training midwives, and that's wonderful. But while doulas and midwives are being tasked with changing this maternal health system, and even clients who are hiring birth workers to engage with these issues, we have very limited power to actually do this work, right? And so that was a huge sort of implication. The one piece of statistics and that I really did want to bring in here to sort of frame this research project was birth workers as witnesses, right? And so there's been a couple of different research studies looking into this, and I'll just give you a couple of statistics from one in particular that found that 65% of birth professionals reported witnessing a lack of informed consent. A third of doulas and nurses surveyed witness practitioners pressuring birthing people to accept procedures against their will, all things that we know that we have seen, but that research is backing up now. So what came up time and time again is sort of this decision-making point around when and how to intervene when harm was occurring. And so we're going to get into that a lot more. The two articles that I sort of wanted to bring to your awareness on the last slides were really, really interesting to me because they spoke to experiences I've had as a doula and in the themes that came up with a lot of the people that I spoke to. The one that really stuck out to me is the one that explores the experiences of birth professionals navigating what they call this sort of like liminal space. And that came up a lot because it's like these birth workers are existing in these in-betweens, right? Like they're hired by their clients to work within these medical systems. They're, being tasked with all these different, it was just fascinating to hear all these different things that they sort of have to navigate like in the moment, in these spaces. And so I'm really interested in exploring that a little bit more because that being in this in between really, really weighed heavily on the work and in folks' ability to sort of stay engaged in the work and not just sort of like leave the field. And so again, that will come up again. One of the participants talked about having to be like a birth bodyguard, which I also thought was pretty just sort of really stuck with me, right? Like that we have to be these protectors, but again, not given the power to really be able to do that. And so that came up in this research and also in the conversations that I had with some of these birth workers. The other article that I highlighted on the previous slide was by Adams, Curtin, and Bowen. And that one is the first of its kind to really look at the relationship between doulas and doctors, and it was fascinating. And obviously they found that the relationship is very complex, right? With doulas needing to sort of strategically navigate and manage their relationship with doctors and their status in the birthing room through what they call deference and subordination. And, very rarely were doulas communicating their clients' preferences directly to their doctors in the room, which again, in some of those early trainings, which we'll talk about, they're told, don't talk to medical professionals. That's not your role. And so oftentimes they found in this study, and I found in my research as well, that the birth workers and even some of the midwives, and most of the time, just to sort of get a little bit more context, most of the time, the midwives, because I was intentional in interviewing independent birth workers, so they're not employed by the hospital, so they're not practicing out of the hospital, they're not affiliated with any OBGYN office. The midwives that were interviewed are usually there in like they transferred from a home birth capacity most of the time. And so that had its own sort of power dynamics that came into play a lot. But most of the time, they sort of had to downplay themselves as professionals and sort of give up power while playing this game, which really weighed into their ability to make decisions about how to intervene. And so again, my work, I took all of this research and my lived experience, because in this particular program, like we even have to put like a reflexivity statement in our paper to say, we recognize that our lived experience is going to influence sort of how we analyze this data and how we sort of put this work together. And so it is important to say that, yes, there is research involved, but there is also this piece that is me, and that is my voice, and that is my lived experience as a birthing woman, and as a birth professional as well. And so I just sort of want to reiterate that again. But again, sort of my hope with this paper, and also just having these kinds of conversations with folks like you, is to be able to better understand the process and the impact on the lives of the individuals who've, like I said, been tasked with addressing the maternal health crisis in this country. And so I just want to take like a minute or two real quick to take a breath. I'm already talking about pretty sort of heavy statistics and issues. And so I don't know if anybody has any burning questions right now, or Wendy, if you want to bring any to my attention before I sort of go on into the themes that are sort of, just to give you a little disclosure, heavy. We're going to talk about some heavy things.
Thanks, Simone. As I'm just reviewing through the chat, I think folks are just really grateful that you're talking about this. There's a couple of little side conversations, just how important it is to bring up these conversations. Jennifer put into the chat that it's great that, we're recognizing that doulas can help and that doulas are getting economic support and recognition. But if there's concern that the person with the least power in the room has to do something or become the responsible party when violence and racism happens, she says, isn't this just another way for the medical community to not look at themselves and their system and take action?
Yeah, I could actually be done, because that's basically my whole point. So yeah, absolutely. Yeah. Thank you. So just to sort of ground us in, what did I ask? What was my point, right? And so these were the official research questions. What types of harm are independent birth professionals witnessing? What factors influence their decision to intervene or not? And then this is what I really wanted to get to. What impact does this experience have on their professional career and well-being? And so I think I had about 12 to 15 questions that I actually asked. Some of those are sort of addressed here. The one thing that I do think is important, and I didn't get to talk about this in my paper, but for the same, we were talking about very difficult things, a lot of trauma, a lot of violence, a lot of vicarious trauma. I did build into my interview questions about not only self-care, but like joy, right? Like, where do they find the joy in the work? How are they finding the motivation to continue doing this work despite all of this? And I think that's really important, because that is that hope, that joy, that is what keeps us doing this work, right? And so I didn't get to talk about it too much in this paper, but it was part of our conversation. I just sort of thought that was really important to say. And also, I'm hoping that this is just, again, part one, because there's a lot that came up that I didn't have the capacity to address in this particular paper. But again, just the beginning of sort of having these courageous conversations. So some of the themes. A lot of different, so when we do thematic analysis, right, we take all of these interviews, we put them together, and we start to draw out these themes. And so there were a lot, but I sort of tried to take them all and sort of fit them into these 4 overarching themes. Some had some sub-themes, which we'll get into, but this was basically how I framed this research paper. So bearing witness, decision-making around advocacy, positionality and motivation, and then fighting the system. These are the things that came up over and over and over again. And now I'm going to sort of break them down a little bit further too. And I will try to pull in some actual quotes where relevant as well. So in terms of what folks saw, all of them spoke about a continuum of violence, as many of you, I'm sure, have experienced. And the spectrum range from subtle behaviors and comments that literally just change the energy in the room, like even just the way a care provider would just stand over a person in labor, little things like that, to, outright verbal, emotional, physical, and even sexual assault in some cases. So there were so many different examples. I couldn't possibly get into them all here, but there were a couple that surprised me. Not surprised me that they happened, but how often the people that I met with talked about them. And some of them include like fat phobia, and sort of like inadequate anesthesia during labor and even during surgery. And the two of these sort of stood out to me because, again, sort of putting on my birth doula hat and my gender-based violence specialist hat, the victim blaming that sort of emerged from these two particular instances was sort of mind-blowing. Um, I would say a majority of the people I spoke to had witnessed, doctors blaming an inability to get a fetal heart rate or to get an adequate cervical reading or any number of things on the person's body size, and would literally say things like, well, you're too big, I can't do X, Y, and Z, or I can't get a good reading because you're too big, or making assumptions about diabetes and high blood pressure before even looking at a person's chart just because of the person's body size. One participant really sticks out to me because they talked a lot about witnessing this. And at the end, they were talking about one particular client that they apologized to them afterwards and was like, I'm so sorry you experienced that. And the person was like, oh, like that's so normal. Like it doesn't even stand out to me anymore. The inadequate anesthesia one really, really threw me for a loop because I would say of the 17 people, at least half witnessed their client going back into surgery without adequate anesthesia. And one particular story stood out to me because this one particular woman was had struggled with substance use in her life, was clean for a couple of years, but everybody in the room, when she would say, or the doula would say, my client is saying that, the epidural is not working, they would say, oh, that's because of her history of drug use. And this particular case, the doula told the resident, the resident actually physically put their hands on this doula, moved the doula out of their way and said, get out of my way. And then when this person was allowed to go into the operating room and continued to advocate and say, my client is telling me they can feel everything that you are doing. And the anesthesiologist's response was, well, that can't be true because they'd be screaming out loud if that was the case. And so to me, that is the same kind of victim blaming we experience when we're talking about sexual assault. Well, it couldn't really have been sexual assault because they would have been fighting back. They would have been screaming, right? And so this is other place where this victim blaming really sort of started to rear its head in the delivery room. And so those things really stood out to me. Another one, a participant talked about, and she used the analogy of a puppet, where her client was experiencing sort of long and lingering vaginal exams, where the doctor would just keep their fingers in, the doula's client and ask them to make decisions with their fingers inside this person's body. And the analogy of a puppet they use, and it's sort of just that has not been able to sort of like leave my consciousness either. Another one, this was a midwife, and they were there for they had transferred from a home birth. And it was a fast labor, and this woman was having a really intense experience, and she was loud. And the doctor came in and actually physically shoved a towel into the client's mouth. And this midwife reported it, but nothing happened. And so those are just a couple that really stand out to me. And there were a lot. And I will say, I did not anticipate the impact having these conversations would have on me after the interviews. And I had to like seek out support from like my mentors and stuff just to be able to get through the rest of my day after having these conversations, right? I did not anticipate that it was going to be as intense as it was. A couple of other things that sort of came out around this were, doulas and birth workers figuring out how to have these conversations with clients, whether that is sort of the person who experienced this, like, did they wait for them to bring it up? Did they bring it up postpartum? or even with new clients. Like, did they just bring up the issue of obstetric violence, and what kind of language did they use, or did they wait for them to bring it up? And some of them said, I waited for them to bring it up, and others were like, no, like I am no longer sugarcoating the experience of childbirth in this country. And I talk about it from day one at an interview. Like, they may not even have hired me yet, and I'm already telling, folks about these issues. Another thing that sort of sat with me a little bit too, that I think you'll all sort of resonate with, is that most of the participants felt supported by colleagues having these conversations. Like, they felt like they had somebody to go talk to after they experienced this. But there were actually quite a few who didn't. And one new doula who was actually encouraged by her mentors to sort of keep her head down and not say anything and not stir anything up in an effort for collaboration, which sort of broke my heart a little bit, because this particular participant talked about, wow, it's 44 minutes already, not having a space to be able to talk to anybody about what they were experiencing. And so that really stuck out with me too. So another theme was, you always have to calculate the risk of speaking up, right? So these decisions about advocacy, deciding when and how to intervene on behalf of a client. Most of the time, and to go back to think about, being aware of all of the power dynamics, being aware of the pressure that's on this person in the room, being aware of like having to support this person using things like, cloth and hip squeezes and stuff like that, but also then having to sort of be this protective factor, right? And so in those moments, there's either like not enough time, or their fear of retaliation or blowback. A lot of the participants were afraid that if they said something, their client would get treated worse. Some were even nervous to wear like a shirt that said, consent-based maternity care, because they were afraid that just wearing that would lead to their clients being treated poorly. And so I just don't think we have enough conversations about how birth workers are navigating these spaces and all these pressures that are on them around this. One other thing, in power and positionality, I'm going to sort of go a little bit faster now because I want to save room to chat. Positionality actually came up a lot, and a lot of the participants identified as members of a marginalized group. So either a woman of color, a member of the LGBTQ plus community, an immigrant, a survivor either of sexual violence, domestic violence, or even medical violence themselves. And they all talked about how their identities were often part of their motivation to do the work. And in this particular study, these participants were more likely to articulate an inability to remain silent when they did witness harm occurring, which I thought was really interesting and sort of as an implication for further research there too. So we talked a lot about sort of power differentials, and obviously we know that it can be a barrier to advocacy, but there were instances where it could also be a strength. And oftentimes it was power in training and power in experience. And the more experience and the more training a birth worker had, the more empowered they felt to be able to step in and say something when they saw something happening, which I thought was really interesting too. And we started to talk a little bit about sort of bystander intervention. Just see, skip a little bit. This one, the sort of the impact was the hardest, I think, to sort of chat about. And the quote I used to sort of sum up this theme was sort of like my greatest joy and my biggest heartache. And they all talked about, how it's exhausting and tragic to witness, burnout and vicarious trauma, how many people had to like seek out therapy specifically because of their work as a birth worker. A lot of them, again, talked about this pressure they felt under to sort of literally be the answer to the maternal health crisis, which was not something I really anticipated coming up so often. And then the other piece that I thought was really, really interesting was sort of, how do you continue to dance the dance in a system that is traumatizing people? And so a lot of the language people used was around fighting the system, arming clients, engaging in battle. One person even talked about creating a birth plan as a safety plan. And now that's something we do with domestic violence survivors, right? Like when they are navigating these violent relationships, we worked to put together a safety plan. And when this, I still get the chills just saying it, because when she said to me, this is a safety plan for birth, it broke my heart that that was where we were, right? Like that we had to arm people with a safety plan to be able to go deliver and give birth to their babies in a way where they were not traumatized or they were not harmed. And, you know, so a lot of these folks had to sort of either figure out, most of them, I will say, were reassessing how they approach this work, right? Like they either were trying to do more home births, or they were trying to focus more on childbirth education. They were stepping away from birth work. How many people had to take a break because of the impact it was having on them? And they recognized that they were not able to give the support they needed to their clients because they were so traumatized themselves. Many of them felt radicalized by birth work. One thing that I thought was really interesting was that, you know, a lot of folks got into doing birth work because they wanted to do birth work, right? They wanted to help people have babies and breastfeed and all that stuff. But what they didn't anticipate was then sort of being radicalized and now engaging in all these other social justice issues, right? Like who's in working in like food justice and rights around adequate health care and racial justice and all these other sort of isms and systemic issues that they had no idea were going to be a part of what they thought was just going to be birth work. And so I thought that was really interesting too. So I skipped over a lot here because I want to sort of hear a little bit from all of you about your thoughts, and I'm happy to, you know, continue having this conversation. And that was just sort of like the tip of the iceberg. This is my little meme. I always have to put in a meme. But what do we do now, right? Like, what is the point of all of this information, right? And I think it's really important as researchers to not just gather this information and then write your paper and then be done with it. Like the motivating factor here is now, okay, we know this is happening, we know the impact that is happening, now what? And so these are just some of the things that came out of conversations around what we can do to create change. One of the things that I think is really low hanging fruit is better training. Every single person I spoke to talked about how they were not prepared to engage in this work. Their trainings were, in their words, inadequate, did not cover things like birth trauma or vicarious trauma or obstetric violence or maternal mortality. Or one thing that we talked about a lot, but I'm really interested in developing now, is bystander intervention. You know, as a violence preventionist, that is our go-to evidence-based practice. We teach people about bystander intervention. And what's really interesting is that we are teaching individuals who may or may not at some point happen upon an instance of harm, and then they have these skills to be able to engage. The difference here is that birth workers are actually oftentimes hired. Like I had one stands out to me where she got a phone call and she said, I'm a Black woman and I don't want to die when giving birth, right? And so imagine receiving that phone call. And so birth workers are actually intentionally going into these spaces where they need these bystander intervention skills, but nobody's teaching them. And so that's something that came up quite a lot too, along with a lot of these other things that are on this slide as well, which of course I wanted to go into a little bit more detail, but I'm rather hear from all of you now than continue to just, as my son says, yap on and on and on. So I will take a break, and I'm curious to hear what you all think about sort of what sort of came up from the themes or your own experiences, or what do we do now as a community of people who care about the experience of birth? What do we do? Where do we go from here?
Thank you so much, Simone. This was such an enlightening, I think, presentation and grounded so much in the research piece of all of this, right? The detail that you've gone through to connect with doulas and learning about all of these different things that we all witness at some point or another if we're in the birth space. I'm going to go through the chat. I really encourage folks to write in. You're welcome to raise your hand if you want to come off of mute, because I know it's hard to articulate everything into a really concise message sometimes. So we'll give folks just a couple of seconds to kind of switch over into another space. I know that in my birth community locally here, that I'm really grateful to have built deep community with my doula friends and other midwives, and have a good support system where we do talk about these things. I was actually just having a conversation recently with one of my doula friends who decided to swear off of doing hospital birth for some time and just focus on birth center or home birth. And we were just discussing that was the best decision for her moving forward with her mental health, but how difficult it was for her to make that decision because it leaves that other 99% of birthing people in the hospital without her as a doula, but that was the best thing for her mental health. And it's hard to have those conversations because it was, stemming from a lot of things that you reported on.
Yeah.
Witnessing in the hospital.
Yeah, that came up a lot, and one conversation in particular stands out to me where this newer doula was really struggling with this, and she said, but I don't want to be in the hospital anymore. My goal is to attend more home births, but the people that look like me don't have the same access to out of hospital birth. And so you could see, even again, getting the chills just talking about it, because you could see the struggle she had. It was like her own mental health or feeling like she's letting down her community because she couldn't put herself in those situations anymore. So yeah, that was very common.
Mm. I see, Vicky, you have your hand up, but it just brings up one more thing to me too, is that, here there are a handful of doctors that I know that a lot of my doula community doesn't like to work with, or that we know if they're birthing at a certain hospital or a certain space, or they have a certain just like OB that we really you just your hair goes up and your red flags just kind of immediately are like, oh, have you thought about seeing another doctor, or who are your options, or all of those conversations. And those are difficult discussions to have with a client, because you don't want to you want to properly educate, but you don't want to instill that fear of moving into a birth right away with saying, well, have you thought about changing your doctor, because they're not great. That's difficult.
Yeah,
Uh,
yeah.
yeah. Vicky, I am going to ask you to come off of mute.
Hello, very nice to meet you, Simone. So I am raising my hand because I'm one of the people that typed in the chat, and it's quite a long chat. So, Wendy, should I just say out loud what I said, or?
Go ahead. Absolutely.
So when you were talking about the drive people have to assist other people, one piece of research that you might want to do in researching what that drive is, Dr. William Emerson has a whole series on how our systems approach getting what they needed, even deeply unconsciously. We don't even have any idea. So there's direct recapitulation, which is what his term for it. And there's avoidant recapitulation. There's identified recapitulation. And then the one you're talking about would be generative, where we go back into the dynamics that have the potential to result in what we experienced. And our goal in wanting to do that is to try to ensure that what happened to us does not happen to other people. And we may or may not be aware that that's part of what we're doing there. And it's really fascinating when you get into looking at some of the stories, because some of the ones who aren't as aware that that's what's causing their drive to be so intense will sometimes inadvertently do things that will set up even more of what they went through, because that's what they knew and that's what their system is looking to get a redo for themselves. It's really amazing. I just wanted to say that. So, um, you'd have to ask him actually at this point where the best source for maybe being able to have access to what he knows about that would be, because I don't know, like a publication or whatever to tell you that you could go for it. But if you ask him about it, he would be able to tell you if you email him.
Yeah. Thank you for that. And you also, and that was Dr. William Emerson, you said, right?
Yes.
Okay.
He's very big on healing of birth trauma for babies and for adults.
Yeah. And I think you bring up one thing that I hope, so with this next semester, we work on this sort of multimedia project where we create something that goes out into the world. And you brought up stories, right? And that is sort of where I see my work going, is getting folks to share these stories. And it's not just people who have been harmed or the birth workers. I think also it's the medical providers too. Like, I think, I do a lot of work around transformative justice, and a big piece of that is understanding the experiences of the people that cause harm as well, right? And so they're overworked, especially if we're thinking about not necessarily the surgeons or the anesthesiologists, but the people that are there really doing the work, the nurses and stuff. They're overworked and they are not supported and they are underpaid, right? And so bringing folks together to have conversations like these, to share their experiences in what I've come to learn is called narrative medicine, I think really does hold a lot of potential in sort of transforming these systems, because we have to hear about what's happening before we can sort of reckon with creating change, I think. And so sort of what you were saying in terms of the stories, we only get to that information by hearing those stories.
Well, and having an opportunity to tell them,
Yes.
A good deal of these people are actually at a heart open space. They're not wanting to do some of the stuff they're doing, but their story hasn't been told, and the story will bubble itself up right through our pores if we don't have a conscious way to engage it. And so absolutely, to create the space where people could just tell their story, never mind trying to get them to understand how important PPN is. I think when we try to like shove that down birth workers' throats, OBs and so forth, it's no wonder they push back. But to just say, what's your story? And yeah, so exactly.
Sometimes it's simple, right? It's just sitting and talking and listening and sharing stories.
Absolutely. Simone, I have another question that came up, and I don't know, maybe speak to this how you can. It says, how accurately do the doula certifying organizations talk about this piece? Their profits are based on consistent and constant turnover of doulas or new doulas coming into this work.
Yeah. So that, I think there is a component of this that I think, whether it's a paper or just another conversation, where that would be the focus, because I think the training and the certifying is a problem. I cannot tell you how many people talked about this and how many people actually said, they would, in these early, doula 101 trainings, and they would raise their hand and ask a question about obstetric violence and would be shut down, like just totally shut down. And to me, that's a huge problem. Also, because another thing that a lot of these people were talking about were a lot of the hospitals were making them, like, you could only come to this hospital if you were certified by this organization. And then that, so it's this cycle of exactly what you're talking about, profit and who benefits from this constant turnover of birth workers and burnout and all that. And I think it warrants a lot more conversation. But I also feel like, for me, that's, again, like I said, like the low-hanging fruit. Like, we could very easily, to an extent, improve training and give new doulas opportunities for mentorship and better training. And a lot of folks talked about trauma-informed care, consent-based care, LGBTQ plus specific training, and not as like add-ons for down the road after you've been doing this work for 5 years, but integral and sort of a component of that very early doula or midwifery 101 training. And so I find that the training and the certifying bodies, those issues are very closely tied together. And I have a lot of those similar questions as well.
Absolutely. Well, I think that the trauma-based information piece, like that's not something that you can learn on the fly. You know, it's not fair to ask our doulas to go in and they're observing all of this obstetric violence or racism or any of the things that you brought up today. And, you know, that's not something that you kind of learn how to, it's not fair to ask our doulas to learn that in the birthing room. You know, we should be equipped to learn how to mitigate those situations and discuss them and not traumatize our doulas either, because it's overwhelming to go into a space like that and take on those pieces as well.
I have a question.
Oh yeah, absolutely.
So like, do you have it like any resources or pages or trainings or suggestions where people can go and learn to get equipped? Because not a lot of doula trainers are doing these kind of talks. And so I don't know, for me, I felt like I had to go and learn and learn and learn and learn and learn and learn. And you know, you still don't feel as 100% equipped.
Yeah. So, I mean, I think there are a lot. So I'll back it up. When I became a doula, there was nothing, right? Like there was, now I do think it's better. But again, it's at the burden of the doula, one to seek, or the birth worker to seek it out, and then also to have to pay for it. And a lot of these CEUs, and they're all wonderful, and we want to do them all, but it costs a lot of money. So I don't know of anybody doing really engaging work around this. I am working with a colleague to try to create something on bystander intervention for birth workers. Birth Monopoly does a lot of great work. And they did, I was going to mention this, but I did see recently, haven't read it yet because it costs like $50, but I do want to check it out. They put together a guide on like how to file a complaint for mistreatment during childbirth, which I think is huge, because a big piece is not having a method for being able to report when something does happen, right? And so I think that is a big piece. I would say what I have found most of the time, depending on where you are geographically, it's going to those community-based doula and birth worker organizations that are doing sort of the really good trainings that are involved. Like I think of specifically, I'm thinking like in New Jersey, we have like Ancient Song Doula Services, and they started in New York. Now they're here in Montclair, New Jersey, and I'm on their birth justice task force. They are doing a lot of work on, you know, teaching birth workers on how to navigate issues of interpersonal violence and trauma-informed care, and what does consent look like, those kinds of things. But in my experience, and I could be wrong, and I'm happy to hear what other people say, these larger, sort of more popular, standardized doula training entities are not necessarily engaging in that. And you have to really go to the grassroots organizations. And a lot of those too will do things like sliding scale because they want to make it accessible. And sometimes they even do like free trainings and stuff too. So I do think that they exist. It's just the burden is on the birth worker to try to find them and seek them out and engage in them. But I'm hoping to use a lot of this research to be able to make training better, right? And more accessible and more holistic.
Well, what a beautiful vision, Simone. Knowing you, I know that we'll get there. I know that you will full force lead us and pull in the perfect people to put all of that together. I just want to call attention. It looks like there's a little comment in the chat of some organizations who do teach that in their basic trainings: Babomia, Cornerstone, BADT, which is Birthing Advocacy Doula Training. I thought there was one other one that I saw. Sacred Birth Doula has a birth rights package. So it's so great because this is a conversation that's coming out to the forefront, and I just give you all the kudos, all the flowers, all the claps, and all the things for continuing to put this into the space of writing about it in an educational space. And I'm so grateful for you to come on today and chat with us. And I know that this is something that a lot of us as birth workers have somewhere in the back of our mind, on our plate. And I'm just so grateful that you were able to come on and share your research with us. That's incredibly important.
Thank you for having me. And I'll put my email in here if anybody just wants to chat. Keep the
Yes,
conversation
absolutely.
going. Yeah. Mhm.
And we'll have to have you back on as you continue to complete all of these different pieces of your of your work.
And I practiced it so many times and I was exactly on 45 minutes and I don't know what happened. So there's a lot that I didn't get to that I think you all would have found really interesting. So I'm, would love to come back and to continue this conversation.
Absolutely. Well, I love that so much. Before we all get ready to hop into the next piece of our day, I just want to remind you all to come back to this space next week on June 10th, 2024. We're going to have Odolan Metz come on. Odolan, I saw you somewhere on here if you want to just give a wave. He's going to be talking about family constellations, what family constellations are, and really delving into the dynamics from before conception, our time in the womb, and birth, and how that emerges often in constellations, and really the resilience and deep difficulty with emotions, the dissonance and trauma that are there in the beginning, and what lives in the soul and what wants to be recognized, and how these constellations we can see the broken connections, how they're found and how they can flow back in with love. And I think, and I'll tease this a little bit, that we're going to do an exercise also in this presentation. So feel free to pop off of mute, all of you, as you hop out for the day, and just thank Simone for her time. And until then, take care.
Yes, thank you.
You,
Bye-bye.
Simone. Really important work.
Take care.
Yeah. Thank you.
Appreciate it.
Thank you so much.